First, the week's top stories from Physicians First Watch, read by its editor, Amy Herman. And then we have a chat with Professor Alex Ford about managing dyspepsia. Here's the news.
Hi, everyone. Our first story. The American Academy of Pediatrics updated its 2007 guidelines on identifying and managing autism spectrum disorder. The guidelines provide a screening schedule and emphasize the importance of early identification and treatment. They also urge clinicians to watch for common comorbid conditions like ADHD, sleep disorders, and seizures. Next, a large meta-analysis suggests that acupuncture may help ease pain in patients with cancer. In randomized trials, real acupuncture was better than sham acupuncture for reducing pain. And when patients got both acupuncture and pain meds, they had better pain relief than when they just got meds. Elsewhere, a study involving over 30,000 U.S. adults finds that e-cigarette use is an independent predictor of chronic respiratory disease, like emphysema and bronchitis. In addition, respiratory risks were higher for adults who used both e-cigarettes and traditional cigarettes than those who used either product alone. Next up, the FDA approved icosapent ethyl, better known as Vascepa, to lower risk for cardiovascular events in adults who have triglycerides at or above 150, plus either established CV disease or diabetes and 2 additional CV risk factors. It's meant to be added to maximal statin therapy. And finally, a study in France finds that people who eat more ultra-processed foods, like packaged breads and snacks, had higher risk for type 2 diabetes. And this finding held true even after adjustment for BMI, physical activity, and other confounders. And that's it for this week and this year. Stick around for Joe Elia's final clinical conversation of 2019.
Dyspepsia is one of the more common reasons that people visit their clinicians. There are several clinical approaches to investigating and managing it, the published evidence on which has been evaluated by our guest, Professor Alexander Ford. He and his group did a network meta-analysis of the evidence in a recent edition of the BMJ, and he's kindly agreed to talk with us about their findings. Professor Ford is with the Leeds Gastroenterology Institute and the Institute of Medical Research at St. James's University Hospital in Leeds. Welcome to Clinical Conversations, Professor Ford.
Thank you, Joe. Thanks for asking me to talk to you today.
For our listeners to understand better what a network meta-analysis entails, let me try to describe it and then see how far off I am. Would it be fair to say that it's like having several groups compare, say, cameras? One group compares Leicas and Nikons, another Canons and Nikons, and another Rolleis and Nikons. Under a network meta-analysis, if the comparisons are carefully done, you should be able to compare, say, Leicas with Canons, even though they haven't been directly compared.
That is pretty much perfect, yes. So exactly that. One would assume that all the Nikon cameras are the same, and therefore the direct comparisons that are made between the Leicas and the Canons with the Nikons can then lead to an indirect comparison between the Leicas and the Canons. So in the case of this network meta-analysis, there are lots of different comparisons of various management strategies for dyspepsia, and in most cases the 5 strategies that we looked at are compared directly with each other, but you can also make indirect comparisons between the strategies as well.
When you did this, you took 15 carefully done trials comprising about 6,000 adults with dyspepsia and looked at the strategies used to manage their illness. Now, the outcome was there at the primary outcome was their likelihood of being symptom-free at final follow-up at about a year. Is that right?
In the trials, the primary endpoint would have been being asymptomatic, yes, or symptom-free at 12 months in 13 of the trials and 18 months in 2 of the trials. But we actually invert that for the meta-analysis. So we look at the risk of being symptomatic at 12 months with each strategy compared with all the other strategies. Yes.
Okay. So the five strategies that you investigated were, and I'll enumerate them. First, a prompt endoscopy. Second, test for H. pylori, followed by endoscopy if that's positive. That's a so-called test and scope approach.
Yes.
The next is test and treat for H. pylori, so no endoscopy there.
Yeah.
Empirical acid suppression and symptom-based management, those five.
Yes.
Okay, so
exactly.
I'll stop talking. and so I'll ask you to describe what you found and how you evaluated those findings.
So we looked at all those management strategies. And as I said, there were direct comparisons between almost all of the strategies. But the beauty of the network meta-analysis is that you can also use all the participants in all the trials to make indirect comparisons. And that increases the total amount of patients' data that is able to contribute to the analysis. And that increases the power of the analysis to be able to detect very small differences in effects. And the background of this, I guess, which you may be interested in, is that previously, this is an area that I've worked in before, we have done trial-based meta-analyses where you just take the data and make direct comparisons. Mm-hmm. And we've also even done individual patient data meta-analyses where we've obtained the original individual level participant data from the trialists to try and work out which of these strategies is best. And that those two previous approaches led to us showing that really these strategies were in equipoise. So prompt endoscopy was slightly better in terms of its effect on symptoms than test and treat in our individual patient data meta-analysis, but it cost a lot of money to do that. So the cost would be prohibitive to a healthcare system with a limited budget or a finite amount of money. Mm. And in our other individual patient data meta-analysis, which we looked at the trials of test and treat versus PPI or empirical acid suppression, what we were able to show there was that there was no difference in effects in terms of symptoms, and there was a trend towards lower costs with test and treat, but that didn't reach statistical significance. So basically, at the point that we came in to do this network meta-analysis, there was equipoise between test and treat or empirical acid suppression, even using individual patient-level data. Hmm. So the reason that I wanted to do this network meta-analysis was that I obviously had this experience of doing the individual patient data work, and I knew that this was a question that we still hadn't managed to answer, and I knew that a network meta-analysis, if we applied the methodology, would be may be able to resolve these issues. And so what we were able to show in this network meta-analysis for the first time is that although there's no difference in terms of the effects of the strategies between each other on the likelihood of being symptomatic at the end of trial follow-up, the network meta-analysis allows you to construct a ranking system which is based on the probability that each of these strategies is the most effective. And what came out of that was that test and treat and prompt endoscopy performed very similarly in terms of their overall effect size on the risk of being symptomatic or the relative risk of being symptomatic, and their probability of those two being the top ranked strategies was very similar. But empirical acid suppression came in much lower, and the probability of that being the most effective strategy in terms of symptoms was substantially lower than test and treat. So the equipoise that was seen between test and treat and empirical acid suppression was no longer present. And the reason that that's important is that currently guidelines, or up until very recently, guidelines have always said that you could use either of those strategies first line, empirical acid suppression or test and treat. And certainly NICE guidance, I'm sure most of your listeners will be aware of NICE in the UK, the National Institute for Health and Care Excellence, yes. So NICE guidance still says that those two strategies, either of them could be used first, and then you switch over to the other one if the patient remains symptomatic. But the recent American College of Gastroenterology and Canadian Association of Gastroenterology guidelines for the management of dyspepsia, which were published actually, interestingly, before we did this network meta-analysis, suggest that you should use test and treat first, and it should be preferred over empirical acid suppression. So actually this network is timely in that it actually supports the recommendations of those ACG, CAG guidelines that were published, I think, just last year. And hopefully as the NICE guidance is updated, they will identify our network in their next literature search, and that guidance will be updated as well. The other thing that's important to point out is obviously the main driver of costs in managing dyspepsia is the rates of endoscopy. So obviously it's kind of an artificial construct that you compare the rates of endoscopy with the prompt endoscopy arm. But of course, everyone is going to be endoscoped in that arm because that's the strategy that you've chosen. But that's going to be the most expensive strategy, isn't it, by definition? So, 95% of people who go into that arm or those arms of the trials will be endoscoped. There'll be a small number of people who actually say, I don't want to be endoscoped because these are pragmatic trials. That's allowed. But the vast majority of people will be endoscoped in those studies, in those arms of the trials. So what you want to see with the other strategies is a reduction, and a significant reduction, in the rates of prompt endoscopy with these non-invasive strategies. You don't want to test and treat everyone and then still end up with 80% of people needing an endoscopy, because obviously that's not going to save money. Right. So what was nice to see again in that analysis was that prompt endoscopy was obviously the worst strategy in terms of endoscopy rates, as would be expected, but test and treat came out on top again, and was the probability was the highest in terms of reducing the need for an endoscopy during the course of the study.
Now, were there any surprises in the findings? Anything surprise you? I'll tell you what surprised me after you tell me what surprised you.
I guess one could argue that it's surprising that people are more satisfied if they're endoscoped, because endoscopy can be an unpleasant test to undergo, particularly if in the UK a lot of people who have dyspepsia end up having an endoscopy without sedation. They just have throat spray, a local anaesthetic, lidocaine throat spray, rather than conscious sedation. So I guess you could argue, or I would say, that I'm surprised that people feel happier having had an endoscopy than having been able to avoid one.
Yes. But that was precisely what surprised me. I thought, really? Well, why can't you just do a blood test for H. pylori and treat me?
Test, exactly. But I think that might relate to, obviously these trials are pragmatic. You can't blind someone to whether or not they receive an endoscopy or not. So people are aware of which strategy they have been assigned to. And it may be that they feel that it's a much more thorough going over if they've had an endoscopy, and they feel more reassured that there's nothing sinister underlying their symptoms. And certainly other people have shown previously that there is a reassurance level associated with a negative endoscopy amongst people with dyspepsia, although it is relatively short-lived.
Yes. And the management approaches, now it seems that endoscopy first would be, as you said, more expensive, and it's also got the albeit low, but low procedural risk of complications that goes along with it. And so all 5 management strategies, when you look at the relative risk array in one of your figures, it shows that they don't really differ, statistically speaking, from one another. Is that fair to say?
Yes, in terms of effects on symptoms, in other words, in terms of their effect on the relative risk of being symptomatic, there is no difference between any of the strategies. None of the strategies are superior to any of the other strategies, which is why the network is useful, because it provides you with the ranking system based on probability, which tells you that test and treat is the most likely to be the top ranked or the best management strategy. In terms of the effect on the likelihood of needing an endoscopy during the course of the study, test and treat was actually superior to all other strategies apart from symptom-based management. So it was superior to prompt endoscopy, as one would expect, but it was also superior to test and scope, so test for H. pylori and perform an endoscopy if positive, and empirical acid suppression.
Now, we've been talking about endoscopy as if it were the monster, the thing to avoid at all costs. However, you do point out in the introduction that there are what you call alarm features that would necessitate or make a clinician think more carefully about just going with test and treat. That would be the age of the patient. I don't know what the age threshold is for when you say we should scope this person.
Yeah, so it's normally about 55 in the UK. I think in America, in those guidelines I alluded to, they've just suggested the age should be increased to 60.
Uh-huh. And dysphagia is another.
Yes.
Weight loss, and anemia.
Anemia, vomiting, so persistent vomiting, which might be indicative of a gastric outlet obstruction from either a pyloric channel ulcer or a gastric cancer.
Yes. And speaking of gastric cancer, among the people who did undergo endoscopy, the rate of finding of cancers was less than 1%, wasn't it? It was like zero.
That's right. Yeah. And would have been probably even lower had not, I think, one of the trials mistakenly included a couple of patients who had alarm symptoms and were subsequently found to have an upper GI cancer. And that's not a surprise. A study from Nimish Vakil, who's a gastroenterologist in Wisconsin, several years ago, showed that the cost of detecting one upper GI cancer in patients aged 50 or over with dyspepsia without alarm symptoms was almost $100,000, because the incidence of gastric cancer in the West is becoming lower and lower, really.
And you also point out that your findings should not apply to Asian countries because of the rate of gastric cancers there is higher.
Absolutely, and also there's only one trial from the Far East, which is from a multi-ethnic country, so Malaysia, where it's a mix of Indians, Malays, and ethnic Chinese. And so only the Chinese patients in that study would have a higher risk of gastric cancer. So the sorts of countries like China, Japan, Korea, Taiwan, they all have a much higher incidence of gastric cancer. So yes, you wouldn't use these non-invasive strategies at such a high age, 55, 60 in those populations. And I think, in fact, the guidance is around about 35 years of age in more high-risk populations.
Okay. And so what would you have young clinicians do going forward then?
So I guess the main sort of implication of this network really is obviously to reiterate that one should avoid and the knee-jerk response of requesting an endoscopy in a young-ish patient who has no alarming symptoms for dyspepsia. And, that should really be, that point is driven home again by the results of this network meta-analysis. And I think people sometimes forget that. But that doesn't necessarily mean that if you are a young physician working in a secondary care hospital, that you should apply the results. You have to remember that the results of this network meta-analysis are based on trials that were predominantly done in primary care or were done on patients who had just been referred from primary to secondary care, so at the first point of entry into the secondary care system. So in other words, as the patient was coming to see a specialist doctor, instead of seeing the specialist doctor, they were randomized to one of these strategies. Whereas the patient that's already been through the system and referred again to a specialist doctor or referred from one specialist doctor to another with dyspepsia, the results of these studies and the results of the network wouldn't apply to that population. So it's important to remember that. But if you are working in primary care, or if you are about to see a patient with dyspepsia who's been referred to your GI clinic or internal medicine clinic from primary care, then you should remember that if the patient is young and there's no alarm symptoms, it's highly unlikely there's going to be any organic cause for their symptoms. 80% of patients with dyspepsia will have functional dyspepsia as their final diagnosis. And in these sorts of patients, the best approach now would be to test and treat them as a first-line strategy. So test them for H. pylori, and then a week or 2 weeks, I think in the US it's a 2-week course of eradication therapy. And if they're negative, then they would probably have a PPI for 4 weeks or something like that. So that should be your first-line strategy. And then obviously if that fails, then you would go on to the other strategies. So you could try empiric PPI if they've already had eradication therapy. And then beyond that, there is always, as we say in the article, the management of individual patients is nuanced, and you have to go by the patient in front of you. And, you would consider an endoscopy if the patient still has refractory symptoms and they're concerned and you're concerned.
All right. I want to thank you very much, Professor Ford, for talking with us today.
My pleasure. Thank you for asking me.
That was our 247th episode, all of them available free and searchable at podcasts.jwatch.org. I'd love your ideas on how to improve these chats. Email me at jelia@nejm.org. We come to you from the NEJM group. The executive producer is Kristen Kelly. I'm Joe Elia. Thanks for listening.